Thank you for attending Bra Day 2022. My name is Jennifer Matthews. I'm a plastic and reconstructive surgeon in Calgary, Alberta, and I appreciate the opportunity to talk tonight about risk-reducing mastectomies. The main objective of this talk is to describe the goals of a risk-reducing mastectomy. I will also touch on the types of mastectomies that can be performed and briefly overview secondary procedures that can be done to complete breast reconstruction. For women who are at high risk of developing breast cancer, they may choose to manage their risk non-surgically or surgically. Enhanced monitoring involves breast imaging every 6 to 12 months. The goal of enhanced monitoring is to ensure if a breast cancer develops, it is diagnosed and treated early. Surgical risk reduction involves mastectomy. This is a procedure that removes the breast tissue to reduce the chance of developing a breast cancer. A risk-reducing mastectomy is most appropriate for women at the highest risk for breast cancer. This includes people with a known genetic mutation. BRCA1 and 2 are the most well-known, but I have listed a few others. Approximately 5 to 10% of breast cancers are diagnosed in people with a genetic predisposition. The second category are patients with a very strong family history of breast cancer in multiple generations. A mastectomy is estimated to reduce the risk of developing breast cancer by 90 to 95%. It is important to note that a mastectomy does not reduce the risk of cancer to zero. This means that for a person with a 70% lifetime risk of developing breast cancer, the risk would be reduced to 3 to 7%. An average person without a genetic predisposition has a 12% lifetime risk of breast cancer. We know that patients that have a mastectomy are less likely to get breast cancer compared to those that have enhanced screening. However, having a risk-reducing mastectomy does not have a significant survival advantage. This is likely because patients who have enhanced screening are diagnosed with breast cancer at a very early and treatable stage and therefore have excellent survival. That said, longer-term data comparing patients who have mastectomies to those who have enhanced screening is needed to look closer at survival in patients who are at high risk for breast cancer. A common question is how to screen for breast cancer following a mastectomy. The National Comprehensive Cancer Network suggests only an annual physical exam, and this is in line with what is recommended in Canada. The residual risk of a non-palpable breast cancer is so small that it does not justify ongoing breast imaging. I will now move on to discuss the three main types of mastectomies that can be offered. A total mastectomy is typically done without reconstruction. The breast tissue, nipple areolar complex, and excess skin are removed with a goal of a flat closure. The patient can remain flat, wear a prosthetic, or have a delayed breast reconstruction in the future if desired. A skin-sparing mastectomy involves removal of the nipple areolar complex and the underlying breast tissue, but preserves the skin envelope. This is done in the setting of immediate reconstruction with implants or tissue. This patient had a left skin-sparing mastectomy and immediate reconstruction using her abdominal tissue. The breast skin envelope has been preserved and used in the reconstruction. A skin-reducing mastectomy involves removal of the nipple areolar complex, the underlying breast tissue, and some of the breast skin. The breast skin that is removed is carefully designed to facilitate immediate reconstruction. Good candidates for this operation include women who desire a smaller reconstructed breast. A skin-reducing mastectomy can also create a very nice shape in the reconstructed breast. This patient desired smaller breasts. She had a skin-reducing mastectomy with the pattern shown on the left and immediate reconstruction with implants. Her final scar looks like an inverted T. A nipple-sparing mastectomy leaves all the breast skin and nipple areolar complex, but removes the underlying breast tissue. This is considered a less complete mastectomy since the ducts of the breast terminate at the very end of the nipple. However, current data suggests that women who have a nipple-sparing mastectomy for risk reduction are not at higher risk of developing breast cancer compared to those who have the nipple removed. Therefore, it is considered a safe option in many women. Good candidates for this operation are women who have smaller breasts with very little ptosis or droop. There are several incision types that can be used, and your surgeon can help decide if a nipple-sparing mastectomy is appropriate for you. This patient had bilateral nipple-sparing mastectomies using an inframammary incision. She had an immediate breast reconstruction using implants. This patient had bilateral nipple-sparing mastectomies using a peri-areolar incision with a lateral extension. She had immediate breast reconstruction using tissue from her lower back called lumbar artery perforator flaps. The final topic I will touch on is common secondary procedures to complete breast reconstruction. I will talk about nipple reconstruction and fat grafting, although there are others. Nipple reconstruction is optional. In general, a tattoo is needed to give pigment to the nipple areolar complex. Some people choose to have a tattoo only, and others choose to have a nipple or bump reconstructed first and then a tattoo. Both options can give an excellent result. It is a personal preference to have a physical bump present or not. Unfortunately, we do not have a method to restore normal nipple sensation. Nipple reconstruction procedures can generally be done under local anesthetic and are done several months after the breast reconstruction is complete. Fat grafting is a surgical procedure where fat is removed from one area of the body using liposuction techniques and then injected under the skin of the reconstructed breast. Fat grafting can be used to improve small contour irregularities, increase mastectomy flap thickness, or help reduce radiation changes. That concludes my talk for this evening. Thank you for attending Broad Day 2022 and enjoy the rest of the event.